Hello, and welcome to Resilience Radio. I'm your host, Irvin Eisenberg, and today's episode is going to be a little bit different. Usually I'm talking with a healthcare practitioner who specializes in something in particular, and we have a conversation around that. Today I wanted to turn the camera or the audio, for those of you who are only listening, to Syn Graham, who is a client of mine who is graciously offered to come onto the show to discuss their experience with my work. Now, the work I'm talking about specifically is the scar work I do post-gender affirmation top surgery. And as a cisgender male, I can't speak to the experience of being in a trans body. As an occupational therapist and a scar tissue worker, I can speak to how scars respond and techniques I do with clients, but I thought it would be good to have the perspective of someone who has the lived experience, and it's so great to have you on. I so much appreciate your generosity and time today.
Thanks, Irvin. It's really good to be here.
So let's start off with what led you to get scar work post-surgery?
I'd like to pull back just a second and give a little bit of an intro myself.
Absolutely, please do.
So, like you said, my name is Syn Graham. My pronouns are they, them. When it comes to my sex, for the most part, I identify as female. For my gender, it's non-binary, queer, genderfuck, something in those realms. So I had top surgery back in April of 2025 and started coming to see you, I believe, right at the 6-week mark. Now, that had been at the recommendation of my primary care physician at All Brains Belong. They work a lot with trans students, They work a lot with trans folks in various stages of medical, surgical sort of transition. And I'd learned from them and from other mask friends of mine how important some form of PT or some form of scar work is after surgery. So right after surgery, I was really aware of how much my mobility was limited because of the scars, because not even necessarily because of pain at that point, but just due to the tissues really gripping onto each other and limiting my range of movement. So that you not only came recommended by my PCP, but also have on your website your talk specifically about scar work, about working with the tissues to help them release, was what led me to reaching out and make an appointment.
So how did the work seem similar to or different than you'd expect other scar work to be?
So I mostly associate that sort of scraping technique with scars, where someone takes basically like a blunt butter knife and scrapes along the tissue to break up the connective formation. And this sort of blunt force approach to scar tissue is what I recall seeing pretty much everywhere else. So the idea of working very gently with the scar, with coaxing it open instead of forcing it open, was really intriguing to me, particularly since I have hypermobile Ehlers-Danlos, which means that my body doesn't produce collagen proteins correctly, and scarring can be weirdly impacted by HEDS.
What you would expect from scar tissue in general versus what you received when you came in. And I guess that could either be what surprised you about the work as being different, and what you expected about the work, and what you feel like other scar techniques might be out there. So I think you addressed that there's a lot of techniques, and I would definitely echo that back, that the idea of scar tissue is break up the scar tissue versus work with and see if you can unfold and release the tissue. But I guess from your personal experience, what did the work seem like as opposed to what you might expect from scar work?
So I didn't have a specific timeline in mind walking in. So it's not that I wasn't expecting to see such a response so much as I went in a blank slate and was left open to be completely surprised by how quickly my scar tissue softened and opened up from the first session with you. You would work on the individual scar line for a bit, giving me a chance to touch the scars before and after, compare the side you'd worked on to the side you hadn't, and even just 20 minutes of work on that first day, there was a palpable difference in the softness of the side you had worked on versus the side you hadn't yet.
It's always great to hear. And one of the things I love about the scar work is it seems to, I don't really understand the science as to why what it is works. And I think that if I waited for the science, I wouldn't be able to do the technique because there's something that seems instantaneous about the work. The real effects are the long lasting ones, but there's something about scars pinking up immediately, people getting a nervous system seeming like it's coming back online, and just a sense of appreciation that people tend to have for their scars that's really fun to be working with and really immediately gratifying. There's something to me that parallels and as a cis man who has not had very many surgeries, I can't speak to this personally, but there's something that seems to really parallel the path of the gender affirmation top surgery in some ways with that. The top surgery itself seems like this surgery that, as far as surgeries go, it's not removing bad tissue like a cancer surgery or going in and repairing damaged tissue, or a lot of the things that we usually think of when we talk about corrective surgery. And it's not plastic surgery in the sense of going in to enhance something for its own sake. It's more borderline in there, but it's not a nose job or breast enhancements. And I'm not trying to downplay people who have that and need that for their identity and sense of well-being or looking better post some sort of accident or cleft lip or whatever there. But there's something very life-affirming that I have witnessed with my clients in the surgery. And there's something less abrasive and remove the bad tissue, because let's be real, everyone's got breast tissue regardless of unless they've had it hollowed out because of cancer. And that regardless of how masculine or feminine a body is, there's going to be some breast tissue. So people who get the gender affirmation top surgery are not removing all their breast tissue. They're creating a contour. And I get to do the follow-up work of working with that contour. How do we get people to embody that contour and explore that in a way that helps them be more them?
Something that worked along those lines for me in particular, while there are some folks who get top surgery just want completely removal, they want it totally flat, I wanted a chest that more matches my bigger body. And so if I'd never had breasts at all, if I were born a cis man and had the body type I do now, I would have moobs of the sort. I would have something in the upper chest, and I wanted a surgery that would create that for me. And over the course of the couple of months that we had worked together, you'd worked not only on the lines of the scars, but the interior scars, the ones that aren't visible through the skin, from where skin had been lifted, tissue removed, and then skin brought back together. And I remember the particular appointment where I had kept massaging over my pecs, feeling how tight that was. And you had shifted your same technique from the lines to over the chest in general. And that had so opened up and released that same sort of tension in the parts of my body that were integrating together under the skin.
It's always fun to follow the integration further than just the tunnel vision that often insurance tends to make me want to view things in. So let's continue in the thread of you talking about being in a larger body and what your experience of being in a larger body and receiving therapy in general, and what working with me was like, because I'm someone who's not obese either, or not overweight, or a little bit overweight. So we have different bodies and different experiences as well there.
Yep, I consider myself exceptionally fortunate, whether it is the force of my personality or I've just been lucky for the doctors I've worked with. I haven't faced the kind of medical discrimination that a lot of fat people do. I will place that within the context of, because of my BMI, which is somewhere north of 35, I did have to go to one of only a handful of surgeons in New England who don't have a BMI cap for doing top surgery on someone. So there was a sense of sort of picking my doctors that definitely helped there. ADHD brain has looped the train around. We were talking about medical fat phobia, being in a bigger body.
And how the experience was with me, if there's anything worth noting there.
I never once felt othered for being fat in your office.
That's very good to hear.
None of the overt suggestions of, oh, have you considered losing weight or whatever have you, and also none of the subtler things, the more microaggression comments. I did not experience any of those with you, and I was very comfortable removing my shirt and being in your space while you worked on my body.
That's
I
good to
know
hear.
that is, I know that is not something that fat patients in general can take for granted, unfortunately.
Are there, and I may have just, it's possible I just dodged bullets of microaggressions without being aware of them. Are there, not trying to further people, trying to make the implicit more explicit, are there
Mhm.
particular common microaggressions that both for clinicians and people in general that one tends to get when they're overweight that might be worth making explicit?
The first thing that comes to mind is treating adipose as bad tissue. So, like, you had talked earlier about bad tissue being like a cancer that has to be removed. A lot of the medical field treats fat tissue like that, treats that as something that is wrong, that is bad. I was listening to a summary of a paper a little while ago that treated adipose tissue as an organ in its own right, much in the same way that fascia these days is coming into being treated as an organ a bit more in common parlance. Things like the importance of adipose tissue for the metabolism in storing energy, in responding hormonally to different signals in the body. For example, if someone suddenly loses a lot of weight due to, be that from cancer or from a crash diet, the rest of the adipose tissues will actually send out inflammation signals, which is what this paper hypothesizes leads to the sudden regain of weight, because that is the body, that is the organ of the adipose tissue responding to this sudden loss. So I would say an important umbrella of the risk of microaggressions is treating fat as something inherently bad, inherently dangerous, or otherwise inherently making your patient have a gap between the patient you have as opposed to the patient you wish you had. And I feel like that gap is how a lot of medical professionals approach their patients, is they want their patients to be the kind of patients they want, the ones that have low-fat bodies, who are exercising and eating according to what the medical field has a narrative around being the correct way, as opposed to meeting the patients and meeting the patient's body where they're at, moving through the world within the context that they are. And so long as the patient is getting their needs met and getting their wants met, the patient is getting the health that they're looking for.
Yeah, I always think that regardless of where someone is health-wise now, shaming them for where they're at with it isn't going to help. And taking it away from being specifically about weight, motivating to have good habits, whether it's sleep habits or exercise habits or dietary habits. I mean, studies have shown that when you watch a commercial that has health food in it or is pushing some sort of diet thing, that usually while people are watching that commercial or within the next couple of hours, that's when they are way more likely to eat unhealthy. So to me, if I want to change behavior, and I don't necessarily consider fat in and of itself a pathology, as an organ or organ system, however we want to describe it, it's a type of tissue. Just like I don't view scars as necessarily diseased. Scars served a purpose and helped hold you together. You couldn't have your top surgery if your tissue didn't know how to scar, right? So these
Good
are
connection.
all important. Yeah, these are all really important tissues, and we tend to get upset by processes, and processes gone out of control is, not to go too far afield, but like if any tissue can be made bad tissue if it grows too much, right? That's what cancer is. So, but to bring that back to habits and how do you get people to help people get to a place of better health, is to meet them where they're at. Me coming into someone who can't motivate to do exercises and I say, here's a long list of 15 exercises, you should really be doing an hour and a half of exercise a day, I know I'm not going to do that. It took me a real long time to be able to get to like doing a half an hour, and that's on a good day, of exercise for something I love doing, which is karate right now. Right. So I know that motivation is rarely sustainable solely by guilt. So meeting people where they're at and figuring out, how do we scaffold this exercise, this activity? How do we just take a moment to pause and stretch or touch your scar and feel like, oh, I have, this is part of my body, is something that I value in my practice, regardless of who I'm working with. We've sort of addressed this, but I wanted to sort of make sure we explicitly had it. So what in the process of working with me felt especially safe? What in the process of me working with you and your scars felt good, safe, the pacing? What about it did resonate for you?
Some of this did end up being fairly vibes based. Like, you and I, from the start, had some great conversations and enjoyed chatting with each other, even before we got me onto the table. The fact that you were masked in your office was a green flag to me, given the potentially vulnerable populations I assume you may be working with. Just having a habit of wearing a mask around patients seemed very proactive and pro-social. So for me, that had seemed an indicator of someone who considers the way he moves through the world. I will say that my is being in your office and on your table are impacted by things like I don't carry a lot of physical trauma in my body. I don't have a background of any kind of sexual trauma or even really any heavy body gender dysphoria. That was to say, heavy dysphoria around my body as opposed to dysphoria around heavy body. I do know that there are plenty of AFAB folk who might have a tough time working with a cis man because of sexual trauma that they hold, or sexualized trauma that they hold, or because of body dysphoria they carry, whether that is gender associated or not. A big part of why I have wanted to be so vocally supportive of your work and my experience of your work is because I feel like I can be kind of that canary in a coal mine. So I can talk about my experiences for others who may be more sensitized in ways that I am not. That I had a good experience. I felt safe in my experience. I felt that this was good information to share with others who may feel more sensitized on these topics.
I wanted to respond to that, but I also wanted to make sure I got a term correct, or have you defined, I think the term you used was AFAB in there?
Yes, thank you. So AFAB is an acronym, AFAB, for Assigned Female at Birth.
Thank you.
That is commonly used in gender spaces, of course, to describe the gender one had been assigned at birth, which can offer context for the way one is trained to move through the world as a child, and how that may challenge or be challenged by one inherent association with their own gender.
So is the term AFAB used primarily by transgender folks, or is it intended to be inclusive of cisgender women as well?
It all depends on context, of course, but generally speaking, AFAB is an umbrella term for anyone who has been assigned female at birth, regardless of gender identity. So that could be cis women as well as trans men, non-binary people who had been assigned female at birth.
So in response to what you were saying, it's interesting to me that, and this has changed over the years, but I think there's always been at least a majority, it's not always a large majority, of my client base has been AFAB. Most of those being cis women, but now that I have more trans clients, even most of those trans clients being AFAB, I think that might be the cultural assumption that women have to be more proactive in taking care of themselves and taking care of other people, and that men are supposed to be taken care of. And I'm a little bit on the outskirts of the medical system in terms of I'm not associated with any major hospital, and I don't tend to take standard protocol approaches to things. So people who are seeking something health-wise a little bit different are more likely to be AFAB. So, or how much is my personality? So to speak to you saying that, but at the same time, everyone has their own traumas. I imagine AFAB individuals are more likely in our society to have them, or at least certain types. Yeah, and it's a very broad generalization, including how I'm using the word trauma and a lot of things. I did just do an interview, which I thought was a lot of fun, and went out as a podcast with the Dad Guild, which is specifically about encouraging men to take care of children, and they presented that as anti-patriarchy. And there's some line from the podcast they were quoting someone else, I think, that there's no greater threat to the patriarchy than men taking care of children.
Yeah.
Which I thought was, yeah. But I think the tangential nature of how I just spoke to you doesn't just show how my own brain works, but how the two of us have a tendency in communications to go, "Ooh, that's an interesting tangent to this." But I feel like a similarity that we both have in how we think is that we find that tangent, but we're also very interested in the core nut of what we're talking about and are able to, most of the time, bring that back in. But to bring that back in, you describe yourself as sort of the canary in the coal mine. And in this case, I get the sense that you're singing, you're actively singing, which means you're not
I'm still actively singing. Yes.
And I also I'm not going to present myself, and never have, as the clinician for everyone, because I want to be open to everyone, but everyone's got their own vibe, and whether or not people work with me is an interpersonal thing that may or may not fit. One thing I'll put out there is I tend to be more chatty and want to go places with people, and some people who just need sort of that more aesthetic. I'm not sure that sort of meditative contemplation practice. I'm not always the best clinician for them. Sometimes I can have a great relationship with them too, but they might leave more emotionally exhausted having chatted with me. Is there anything else about the work and working with me that you would like to let people know, warn them of if you want as well?
You were always verbally clear when you needed or wanted me to move to a different position, and when you were about to put your hands on me. Which, for someone who is much more sensitized to being touched, especially by someone who identifies as a cis man, that is incredibly helpful for feeling emotionally and psychologically safe, for setting up one's own expectations and anticipating the touch of another. So I would say that is a really wonderful practice that you have developed.
Thank you. I'm glad has served you and our work together. One thing I did want to touch on, not directly related to that, but you had mentioned my masking. As of recording this video, I still mask for the vast majority of my clients. It is a default unless there is a compelling reason not to mask. I still mask with all clients. Where that comes from, because some people are like, okay, is he just extra anxious? As you said, I work with a lot of people who are either very concerned about their health and anxious about their health, or have immunocompromised states, and it's an easy thing for me to do mask. I got used to wearing an N95 in the nursing home during the height of COVID, and that became my comfort and my barrier. So putting on the mask is sort of putting on my clinical hat, so to speak, over my mouth.
I was going to say, this actually might be the first time that I have seen your face between your nose and your chin.
Yeah, and it's a little bit more hairy than it often is, but no, that might not be entirely true. I'm overdue for a trim. But yeah, sometimes when I see people in public, because I'm not always wearing a mask in public, I might go through the co-op with or without a mask, depending. But I'm not leaning over someone breathing on them. People will have a moment of recognition, and I always speak with clients as much as they want to speak. I consider it HIPAA stuff. I like seeing people in public, but I don't really fully acknowledge them unless they want to be acknowledged, which is a good crutch for me as someone who has face blindness, prosopagnosia, because I have plausible deniability that I didn't recognize someone who I really should have.
You and me both. I have started alerting people as I meet them. If I see you in a different context and I don't recognize you, it's not you, it's my synapses. My brain just doesn't work that way.
So I'm known to put my hand over my mouth and go, yeah, now do you recognize me more? And people laugh because they do. They're like, I'm not used to seeing this.
Yep.
And it's a bizarre thing that happened in COVID. I almost feel like there's it's almost like indecent to have your oh no, I see your lips.
Ooh.
we've touched around the subject of neurodiversity. All Brains
Mm-hmm.
Belong is how you originally, one of the ways you originally found your way to me, and that's the
Mm-hmm.
idea of neurodivergence. We've discussed ADHD. I don't have a diagnosis, but I'm sure I easily could have a diagnosis, and some of your other neurodivergence. Can you speak about your experience of being neurodivergent in terms of clinical settings and working with me or anything along those lines that's worth sharing?
Sure. Well, I identify as ADHD, which is to say both autistic and have ADHD. For personal reasons around safety feeling, I have not sought an autism diagnosis because that can honestly bring more dangers in the healthcare system than it solves, at least at where I'm at for the kind of supports that I need. I do have an ADHD diagnosis, and my experience of those neurodivergences in a world that is built for allistics. So an allistic person is someone who does not have autism or ADHD. My experience of it is just kind of like running a different OS. So like most of the world is built around a Windows system, but there's still a good percentage of us running Mac OS. And some of those interface well with Windows and some of it not so well at all. But Mac OS to Mac OS translates a lot better than between Mac and Windows. So as someone who is neurodivergent, working with someone who, whether you identify as neurodivergent, I might declare you peer-reviewed as neurodivergent. I very much felt a click, and I think that has been a big part of what has helped our chat together really flourish.
Sorry, being peer-reviewed neurodivergent. It's probably one of the funnier things that's been said to me in a while. I thank you.
Those are the three ways to do it. You've got your official diagnosis, self-diagnosis, and peer-review diagnosis.
Okay, so there we go. I've got at least one of the three, and
so much like a lot of the other ways that people can be othered in the medical community, unfortunately, neurodivergent folk see a lot of minimization, a lot of denial, a lot of gaslighting by their medical professionals. And that can build up in a lot of medical trauma, unfortunately, for folks who have sensory sensitivities or who have a particular sense of the amount of information that is necessary to convey to get their point across, or who can feel triggered, can feel scared when they feel that they are being misunderstood and not believed. So with my experience at All Brains Belong being a very overtly neurodivergence focused practice that you had come recommended had really helped me feel comfortable coming in, confident that my neurodivergent way of taking in the world would not be seen as an impediment or a reason to treat me as other, as too much as aggrandizing or any other way that unfortunately can come up in a medical interface. So that I was able to come in and from ground up feel believed, feel as an active participant in my own healthcare, working with someone who has a degree of mastery over the different ways that bodies can show up, both in how they move through the world and how those bodies respond to a trauma, whether that is surgical trauma, like what I had with the scar work that I wanted to have done to bring ease, or the things that come up with aging or with disabilities that can bring pain into the body, much in the way that disabled folk can be infantilized, minimized from being really believed of being the masters of knowing their own bodies. It felt like a partnership working with you, that in this I was the master of knowing my experience of my body, and you bringing your mastery of body mechanics, body movement, patterns of relationship between the self, whether that is emotional, psychological, etc., and one's body.
I feel like I've always, the interaction to me is key. I'm not someone who is good at, I'm better at it than I used to be, but is maybe good isn't, I'm not someone who's inclined to engage in solo meditation. Solo meditation is me sitting there experiencing my body, and that's, I'm not necessarily uncomfortable with that, but I'm much more interested in how my body is in relation. So something like an Aikido practice or a contact improv or energetics of closing your eyes and trying to track the other person's hand, which is what things I used to do more. Those interest me because I'm having to be aware of myself in relation to others. If I were to be the sage on the stage telling you exactly what you should do with your body, exactly what diet you should eat, what exercise you should have, how you should move, aside from that being a lot of responsibility, I can't do all of it. And I'm not a computer programmer of biological beings. And I would be terrible at that. That what I can excel at, what I can offer people is another perspective for the dynamic ecosystem biodiversity that is their body.
Yes.
To organize around. And that takes a lot of the I can't be a perfectionist of move exactly this way, eat exactly this thing, think and do in this way, because I'm not programming you. I'm making a suggestion to a system. I'm lifting a rock in the river and seeing the dams move and the water channels move. And I'm not just building the water channel from scratch. I'm not an engineer.
The language I might suggest is you don't give answers, you offer tools.
Yeah, I like that.
Tools, frameworks, something like that.
Options. Options. Because perfect option, the ideal medicine for your diagnosis might not be the right tool for you. So I have to offer it, right? Even if this textbook, the exact, you should be taking this pill at this time. It's like, well, what if you sleep during that time? But so to me, the perfection doesn't, the perfect ideal thing isn't as important as what's going to be taken. And that goes for exercise, right? It's if people are waiting for the perfect exercise for their body and their condition, then they might always be seeking the perfect exercise and use it as an excuse to never exercise or move. But I wanted to bring this back because as we have a tendency to we've gotten very big in sort of, which is important. The relationship is what a lot of it comes down to. And I would say even relationship, as I'm showing with my hands here, there's the scar and how the tissues line up in that relationship, right?
Yes.
And what does it mean to be having one tissue that's different from another tissue that was not neighbors prior to another tissue become neighbors in the case of this type of surgery. So that's me trying to lace this back together.
Yes.
Can you speak to what changed over time for you? What did you get out of, from a physical standpoint or from a self-awareness standpoint, however you want to speak of it? What did you get out of having the scar work versus if you didn't get scar work?
Well, without a crystal ball, I couldn't tell you whether what we had worked on changed the impact as much as it did the timeline. Maybe it did. I don't know.
We can't do a double blind of you.
As it happens now, it definitely brought a lot of physical ease. I had mentioned tension and tightness, discomfort, and the work we did together absolutely eased that. After we had done the first session beyond the lines of the scars and over the pecs to open that up, I noticed a deflattening of the space of that tissue kind of plumping up into a more comfortable, natural tissue shape, and that both physically and my sense of relationship with gender as shows up in my body. That was a really good session. That felt really good to walk out of there and to both feel and see more curve to the shape after your work had helped relieve the tissue to rest in a more natural space.
One of the things I love seeing with longitudinal scars like the mastectomy scars is you've got tissue here and tissue here, and they're not necessarily communicating because there's now a tourniquet between them. And as you, even if you never remove the image of that line, you having the force transmission and the sort of the plumping up of the tissues such that the north is talking to the south versus it just being more like an hourglass where everything's getting stuck in the middle, right? Or having to be funneled through, having that force transmission. And that's sort of if one way to put structural integration in a nutshell, which is the type of body work I sort of trained in for quite a while, is how do you have smooth force transmission through the entire structure in a way that's structurally integrating the body, right? So in this case, you were structurally integrating the scar by having force move through it. And that can result in order to do that, if things are tied down, is it needs to kind of plump up and connect, because it's being tied down by this scar tissue. And that scar tissue, as we said earlier, it was there for a reason. And you couldn't have had the surgery you had. Many people would, I don't know how we'd really survive as a species without the ability to create scar tissue. So I really don't want to demonize the tissue, but it's done its job for you. And now how do we coax it back into at ease so that it doesn't have to be laying down and holding the tissue down in the way it was, so that you can have a more integrated, in this case chest, but integrated structure in general.
Yeah. It felt like a bookend to the mentality I brought into my top surgery, not only the gender-affirming top surgery of last year, but also when I was 18, I had a breast reduction surgery, and I would focus in a meditation, talking with my body, talking with my breasts, with, okay, body, we're going to go into a traumatic experience. We're going to get cut open. It's going to be painful, but we want this. This is a good thing. It is going to hurt at the time. We're going to have to heal from this, but this is absolutely a good thing that we want to happen. So going into the surgeries with that mentality, coming out from the other side, really kind of feels like the next step in that conversation with the body of, okay, we've been through the really hard parts. You have done such an incredible job building up the scar tissue that has gotten us through the surgery, that helps hold us back together. We don't need all of that anymore. We can let that go. So that holistic conversation between myself and my body, and your hands and your knowledge as tools conversing with my body, really worked well together.
I'm so glad it was as helpful for you as it seems to have been.
Yeah.
Do you have any other considerations for someone who might be considering scar work? What would you like them to know?
From my understanding, of course, you will have less pain and stiffness overall if you get it done closer to the creation of the scarring. But my understanding is no scar is too old to be worked on. There is always more space to coax the tissue into. So even for folks who had gotten their surgery last year or 5 years ago, if they're still feeling some kind of disconnect or some kind of tension, I would say it's absolutely not too late to go in and help your scar tissue release.
The going understanding of how scars work and release and our scientific knowledge doesn't seem to support that lived experience and that clinical experience that I have. But as I said, like there's this idea that, the scars can work a little bit, but there's this prime window. And my experience has not been that that's the case. My experience has been that this work tissues seem to respond quicker than they should based on what we understand of scars.
Yeah.
I have theories as to what that is and hypotheses that have some support, but I'm not going to get into all that at the moment. But also the idea that window, both how quickly the tissues respond and how long out it can. The woman who taught me how to do the scar work, she actually has her own, we have a podcast episode with her that people can check from earlier on, Sharon Wheeler, but I saw her work with people who had 50-year-old cardiac scars. And I saw the scars the tissues kind of come back online in a way and pink up and jump-started the healing process on a 50-year-old cardiac scar. I didn't even know they had done cardiac surgeries like that 50 years ago. So yeah, absolutely. There isn't necessarily, there might be a prime window in which the work can be done and the greatest return on investment. And I don't necessarily even know what that window is, but I do know that most people who I work with a scar, if we jive, if I'm not the wrong clinician for them, usually we can get the tissues to do something positive. You've been listening. Well, do you have anything else you'd like to add before we wrap up? That seems like a nice note, but
Yeah. That's everything I've got. I will say, if you get any sort of feedback from this podcast, folks have any follow-up questions, I would be very open to being reached out to. I'd love to follow up in any way that folks would find helpful.
Great. I'll put some of your information in the show notes there. You've been listening to Resilience Radio. I'm Irvin Eisenberg. We've been talking about scar work, specifically scar work post-gender affirmation top surgery, and a personal account on that. It's been a fun conversation. The music was brought to you by Aaron Marcus with their tune Some Biological Process. You can check the show notes for full credits on that as well. And until next time, take care.